A warm welcome to the Kiel Imaging Seminar. It's a great honor to have you all here today, and it's my pleasure to introduce you to the speaker of today's seminar, Dr. Stefan Sawall. Dr. Sawall is both a physicist and a biomedical engineer. He received his PhD in medical physics at the Friedrich Alexander University of Erlangen-Nuremberg in South Germany. During his PhD, he developed new reconstruction techniques for cardiac and respiratory gated micro-CT imaging. Currently, Stefan is working as a postdoctoral researcher in the X-ray imaging and CT division of the German Cancer Research Center, DKFZ, which this group is headed by Professor Marc KIS. So he will now talk about his research in the development of advanced micro-CT imaging systems and the implementation of novel methods and applications in clinical photon-counting CT. So a little bit of housekeeping. So please wait with your questions until the end, and then we will have a great discussion. So please, Stefan, the stage is all yours.
Thank you for the kind introduction. I'm Stefan, as Heimo already said. I'm a postdoc in the division of X-ray imaging and CT at the German Cancer Research Center in Heidelberg, headed by Marc KIS. We are a research group of approximately 25 employees, consisting of bachelor and master students, PhD students, and postdocs. And we are located in that beautiful building shown on the left-hand side of this slide, and the Neuenheimer Feld. And as a CT group, of course, we have access to a variety of CT systems. They are listed on the slide as well. So probably the most famous one right now is the Atom Alpha, which is the first photon-counting clinical CT system. And we will see more of this later on. Today, I want to give you a brief overview of our research activities in computer tomography. Of course, we cannot discuss all research we are doing, so I picked certain topics that I find particularly interesting. So I want to introduce a classic algorithm to you called RISC-TCM. Then I want to go over some topics in photon counting CT, and I want to close with potential novel applications in CT using artificial intelligence. So let's get going, and let's start with an algorithm we refer to as RISC-TCM. The abbreviation TCM means tube current modulation, which is a technique that is available on every CT scanner, and we have a new variant thereof. So what is tube current modulation? Let's say we measure a patient as shown on this slide, and as you can see, that patient is somewhat elliptical, right? It's not a circle, but it's asymmetric. And if we assume that our X-ray source emits a very constant tube current, so basically the same number of photons from every angular position, then we find that depending on the view angle, only a very limited number of photons reaches the detector. So in this case, if we irradiate our patient from the left-hand side, the detector on the right-hand side will only measure a very low number of photons. While if we have if we irradiate the patient from the front, the detector in the back will measure a lot more photons compared to the side. And since image noise is governed by the projections with the lowest statistics, this results in the formation of these noise streaks you see in here. They were very common when CT was first introduced. However, they completely vanished as soon as tube current modulation was introduced. So what is tube current modulation? In tube current modulation, we actually change the tube current based on the patient's anatomy. So in case of a lateral view like here, we basically would increase the number of photons we emit at this position to make sure that a certain number of photons actually reach the detector and contribute to a signal. On the other hand, we might reduce the number of photons for views, for example, from the front to the back, to make sure that the overall dose stays constant. From a mathematical perspective, this tube current modulation curve as function of view angle alpha is chosen such that the variance in the CT reconstruction is minimal. So we know that X-rays reaching the detector follow Poisson statistics, as shown on this slide. This is this first equation over here. And then we can perform a variance propagation to projection domain, and in the following step to image domain. So basically, this here is a term that basically represents the image variance that we want to minimize. And this is already one of the main drawbacks of what we see here, because with this cost function that we formulated down here, all we do is we minimize solely physical quantities, in this case, the image noise. So we do not consider any particular risk our patient is exposed to due to the ionizing radiation used in CT acquisitions. If we minimize this cost function, this yields that our tube current is somewhat proportional to e to the power of the projection value divided by 2. So one might ask, what does this mean? Well, as a rule of thumb, let's just say that in the middle of our patient, the number of photons should be constant for all view angles. This is what's represented in this equation. However, as I already said, all we consider here are physical quantities. The patient risk and its risk and the patient's risk to develop cancer, for example, as a consequence of repeated CT examinations is not represented in these equations. Of course, vendors also recognized this and introduced so-called organ-specific tube current modulation techniques. They have different names depending on the vendor. In case of Siemens, for example, this is called X-Care. And what it does is, in case if the X-ray source is in front of our patient, it reduces the tube current over a range of 120 degrees. This is done to basically protect sensitive organs and tissues like the breast, the thyroid glands, or the eyes. However, this is still not very adaptive to our patient because this only considers like the tube position in front of the patient and nothing else. However, what we want to do is we want to recognize actual organ positions and the risks involved for every organ in our field of view. This is a nice example on this slide here. What you see here is like a radiation sensitive organ, the colon, in a very elliptical shaped patient. So what classical tube current modulation does is it increases tube current for lateral views. This is indicated here with red, and it reduces tube current here for anterior posterior views. However, the issue with that is that this results in a very high dose administered to the colon in that case. And this is a real issue because such methods do not account for the organ positions. And we want to design a method or develop a method that does exactly that, that recognizes organ positions and minimizes the actual patient risk in terms of the effective dose. So how do we go about that? Well, to be able to compute a tube current modulation curve that recognizes the different risks of different organs, we need to know where these organs are prior to the actual CT scan. We propose to use two orthogonal scout views or topograms that allow us using deep learning methods to basically obtain a very coarse reconstruction of our patient. However, other vendors, for example, recently introduced 3D topograms using very thick pre-filters, so this is also an option. So we start off with a very coarse reconstruction of our patient and then segment all relevant organs of interest. In this example here, for example, you can see the stomach, the parts of the liver, parts of the intestines, the bones, and the skin. We then perform a dose estimation, a very quick one called deep dose estimation. I will tell you about that later on, to really find the dose distribution in our patient for every view angle. So this is something we need to finally come up with a tube current modulation curve that minimizes the effective dose to our patient, such as the patient risk. We just saw this equation we minimized for the conventional MAS TCM. So this is what's available at every CT scanner that's installed in clinical practice. And we modified this equation, and this is shown down here. What we did is we, of course, also minimize image variance, but we also introduced this term for the effective dose or patient risk into this equation. And with that, we can obtain tube current modulation curves that actually minimize patient risk. But to do that and to know that effective dose, we have to do everything I just showed you on that slide. That means we need a coarse reconstruction, we need an organ segmentation, and we need a fast dose prediction. Because the time between topogram and actual acquisition should not be too long. So in particular, this dose estimation needs to be rather quick. The question is, does it work? And this slide shows an example. Middle top is the standard or state-of-the-art MAS TCM that is available at every clinical CT scanner. Bottom right, we have the organ segmentation, and this ring around this organ segmentation basically indicates the effective dose as function of view angle. So these whitish areas here indicate that from this direction, our patient would be exposed to a comparably high dose in terms of effective dose, and the same applies here. So also here, our patient would be exposed to a rather high effective dose, and his risk would increase. So this is not considered in MAS TCM, as I just explained. In these figures here, the dark ring basically is the tube current modulation curve, and what we see here, that the tube current is slightly increased for lateral views, and that it's slightly reduced for anterior-posterior views. However, if we now switch to the proposed GRIS TCM method, we see that X-rays are primarily emitted from angular directions where our patient does not receive a lot of effective dose. This can be seen from comparing bottom right to bottom mid. And this is basically the entire trick of this algorithm. The lines with the values here are twofold. First, we said, okay, let's say we keep the effective dose constant. This is 100%. This is the top line in each figure. And if we compare now MAS TCM to RIS TCM, we find that at the same effective dose, we can reduce image noise to 37 Hounsfield units from 48 Hounsfield units. However, usually in clinical practice, doctors are more interested in keeping image quality constant. This is the bottom line in each figure. And what we did here is we said, okay, let's fix image noise at 50 Hounsfield units and see how far we can reduce the effective dose for our patient with this RIS TCM approach. And we find that we can reduce the effective dose by almost 40% without reducing the image quality. And I guess this is a very nice result because this is something that can basically be implemented in today's scanners because each scanner is already capable of modulating the tube current. And this would be a great achievement to basically reduce the effective dose with a simple algorithm. To summarize this project, we could show that all anatomical regions could benefit from RIS TCM. The highest potential effective dose reduction is seen for the abdomen in comparison to MAS TCM. And we could, in these cases, reduce the effective dose by about 31%, for example. However, as I already said, all anatomical regions benefit from this algorithm. And it's quite easy to implement other risk measures other than the effective dose we used in our experiments. Another topic we are heavily invested in right now is, of course, photon-counting CT. I guess you are all aware of how that works, but let me summarize it real quick. In case of conventional X-ray or CT detectors, an X-ray photon is absorbed in a scintillator. This results in the emission of optical photons, and these optical photons are guided towards photodiodes where the electrical signal is eventually formed. In case of novel photon-counting detectors shown on the right-hand side, this scintillator is replaced by a semiconductor, and the absorption of an X-ray photon results in the formation of a charge cloud, and using an applied bias voltage of, let's say, 1 to 2 kV, these charges are transported to electrodes or the new pixels of these kinds of detectors. However, to account for the high X-ray flux rates in clinical CT, these pixels or electrodes need to be rather small compared to the pixels in conventional CT detectors. And this will allow us to achieve a much higher spatial resolution, as we will see in the following. One thing we could do is we could invest this very high spatial resolution into a radiation dose or image noise reduction. So how would we do that? Let's say our measured signal is g of x, and our measured signal is composed of our ideal signal f, a pre-sampling function, and an algorithm factor. Let's say that pre-sampling function is just a rectangle, and it is basically the detector aperture. And we summarize this pre-sampling function and the algorithm factor into our point spread function P of f. If we now bring this to a frequency domain, we call it modulation transfer function, or MTF. And we can find a formulation for image variance that states that variance is proportional to MTF squared divided by the pre-sampling function squared. So what does that mean? Let us consider two detectors. The detector A is rather large in red, and the detector B has rather small detector pixels. So A is basically a conventional energy integrating detector with large pixels, and detector B is a novel photon-counting detector with very small pixels. In these cases, the pre-sampling functions differ significantly. In case of the large detector with the large pixels, the pre-sampling function is rather small. In case of the detector with very small detector pixels, this pre-sampling function is comparably large. If we reconstruct both data sets, for example, that we acquired with one detector and the other to the same spatial resolution, to the same MTF basically, then this equation only differs by the pre-sampling function. And this means if we divide by a larger pre-sampling function in case of smaller detector pixels, we obtain a smaller image variance. And this is the approach to reduce image noise or radiation dose in photon-counting detectors. This is somewhat counterintuitive, but I will show you in the following slides that it actually works. And this effect is something that we call the small pixel effect, because it's basically caused by the fact that we measure with very small detector pixels, and this allows us to reduce dose or noise. Again, we here see the spatial resolution on the x-axis. So left is a very high spatial resolution, and right is a very low spatial resolution, and the y-axis shows image noise. And in red, again, the detector with very large detector pixels, and in green, the photon-counting detector with smaller detector pixels. And according to this equation, we find that basically the detector with smaller detector pixels will always result in a lower image noise when reconstructed to the same spatial resolution as the detector with larger pixels. However, of course, you could also invest that in an increase in spatial resolution at the same image noise. This is also possible, and I will give you a couple of examples in a second. As I already said, we have access to a photon-counting detector. This is the Neotom Alpha. If you followed the RSNA yesterday, there are now just a couple of photon-counting systems available. So this is now just one of them. And this detector or this system offers two detector modes. One we call the standard mode, which has rather large pixels, and the other one we call the UHR mode, which has very small detector pixels. And these small detector pixels are usually just bin to obtain those larger M4 detector pixels. We performed a couple of phantom experiments at 120 kV, reconstructed that to a slice thickness of 1 millimeter, and we basically tried out every spatial resolution level that is available at the system, and we quantified image noise and radiation dose. And here you see a nice example of how these measurements look like. Left-hand side is an acquisition performed with the standard mode of the detector, resulting in an image noise of 85 Hounsfield units. And on the right-hand side, you see acquisition acquired using the ultra-high resolution mode, also reconstructed to the same spatial resolution and acquired at the same radiation dose. And we see that this only shows noise level of 62 Hounsfield units. So basically, due to the small pixel effect and by measuring with small detector pixels, we were able to reduce the image noise significantly. And this decrease or reduction in image noise is more pronounced for sharper convolution kernels. So if you reconstruct a very, very poor spatial resolution, here indicated by a B36 kernel, then in the end, there is no difference. There's a small pixel effect will vanish. However, if you increase the spatial resolution of your reconstructions, so typical clinical convolution kernels are like 56 or 64, you actually save a lot of radiation dose when measuring with these small pixels. This is shown on this slide. So we quantified the radiation dose reduction for every convolution kernel, or basically spatial resolution level. So again, right-hand side is a very poor spatial resolution. Left-hand side, B76, is a very high spatial resolution. And if we reconstruct data to such a high spatial resolution, we could demonstrate a radiation dose reduction of up to 80% when measuring with the small pixels compared to the larger detector pixels. And this is something that will benefit every patient in such a scanner. Here are examples obtained in a cadaver scan. This is a part of the inner ear of a patient. Top left is a conventional acquisition obtained in an energy integrating detector indicated by EI here. And there we measure an image noise of 89 Hounsfield units. However, if we measure the same specimen with a photon-counting detector and use the very small detector pixels of that photon-counting detector, but reconstruct the data to the same spatial resolution we see in the photon-counting, in the energy integrating system, then we end up with a noise level of only 62 Hounsfield units. So we are able to reduce image noise significantly. And of course, however, we are always able to reconstruct the photon counting data to a very high spatial resolution if need may be in clinical practice. This is another example that shows the same. This is basically a thorax scan. We have the lungs here, we have the heart here, and with an energy integrating system, we measured a noise level of 94 Hounsfield units. And when switching to the photon counting system with the small detector pixels, we could show that we can reduce the image noise to 74 Hounsfield units at the same radiation dose and at the same spatial resolution. And what you see here very nicely is that, of course, you can reconstruct the photon counting data with very high spatial resolution, shown bottom right on the slide. However, of course, a high spatial resolution always results in a very high image noise. But besides reducing image noise, we can also reduce radiation dose to the patient. Again, this example, top left is the energy integrating image with 94 Hounsfield units, and bottom left, we now see an acquisition with the photon counting detector that results in the same noise level. However, the radiation dose to achieve that noise level was 35% lower in the photon counting system compared to the conventional energy integrating system. And this is, I think, also a very nice application. As I already said, every patient can already benefit from this. Usually medical doctors are quite surprised when they see images with a very low noise level, because they always think, okay, you used a lot of radiation dose, but actually that are just images obtained using the photon counting system and using that small pixel effect that is available in these detectors. So far, we just invested our high spatial resolution into radiation dose or image noise reduction. However, one might also ask, what new applications can we design for clinical CT now that we have this very high spatial resolution? And one application we're actively working on is dental imaging. Current gold standard for dental imaging is digital volume tomography. Some of you might already know that. If you are at a dentist, they have basically a cone beam system that rotates around your head. You have to stand still for like 30 seconds or a minute. Excuse me. And of course, standing still for like 30 seconds or a minute is a real issue for either very young patients, children, or very old patients. And if one could perform such measurements with a clinical photon counting CT, that would also be a very nice application. However, so far this was not possible with conventional clinical CT because the spatial resolution was just not high enough. On the left-hand side, you see the acquisition of a tooth of a patient acquired in a conventional clinical CT, and in the middle you see the corresponding acquisition performed in a photon counting system. And I guess we all can agree that the spatial resolution in the photon counting system is much better. The delineation of all relevant anatomical structures shown on the right-hand side is much clearer in case of the photon counting system. You can clearly see this lesion in this tooth over here. And I guess this makes a point for dental imaging in clinical photon counting CT. We also compared this, of course, to the gold standard, the digital volume tomography system, and could show that in particular this alpha system we used for the clinical photon counting CT acquisitions is significantly more dose efficient at the same spatial resolution compared to the gold standard of DVT. Another potential application that might arise in several years in clinical photon counting CT is dedicated breast imaging. The gold standard for this right now is mammography. So basically an X-ray image of the female breast under compression, and this compression is rather uncomfortable for the women. It sometimes causes pain and also might limit the number of patients that come back to these kinds of examinations. So our hope is that using the high spatial resolution of photon counting CT, we at some point can do breast imaging with clinical scanners and replace mammography. However, this is years or 10 years, something like that off. What we did to investigate this is we used a breast phantom as shown on the left-hand side of this slide. I have to agree it's not very breast-shaped, but it will do the trick. And we measured it not only in a clinical photon counting CT system, but also in one of the new breast CT systems. These breast CT systems are dedicated CT systems where women lie in prone position. The breast basically is imaged with a CT device that's located under the table. However, that's not that important right now. And this phantom contains various structures of interest. So in breast imaging, one is often interested in calcifications, fibers, and of course in some muscles or lesions that might be seen in these acquisitions. And this is also what this phantom contains. And we investigated how well these structures or lesions can be visualized in a photon counting CT system. This is shown on this slide for different dose levels. So one might ask, okay, why are we using these dose levels? Well, a dose level of 12.5 milligray CDDI 32 centimeters is roughly what is administered in a scan of the cervical vertebra. And in these measurements, the breasts are always included. And 1.3 milligray is the maximum dose we are allowed to use in the lung cancer screening that was recently introduced in Germany. So this is why we investigated this. And what we find is, in case of at least the calcifications, that we can, in case of a rather high dose level of 12.5 milligrays, we can see those calcifications in our experiments. However, if we go to lower radiation doses, like 1.3 milligrays, we only can see rather large calcifications with a size of, let's say, 400 micrometers. As I already said, we hope that breast imaging will someday be viable using photon counting CT, but right now we are not there yet. To summarize photon counting CT, I think that photon counting detectors are an intriguing new technology. The first clinical approved photon counting CT already offered a significant radiation dose and contrast agent volume reduction out of the box. The high spatial resolution could be invested towards a significant dose reduction. On the other hand, the high spatial resolution might enable novel applications such as dental or breast imaging that I just showed you. And long term, we hope that new contrast agents will become available that also will enable novel applications. Another topic we also are heavily invested in right now is artificial intelligence for CT. The very first experiment we performed was back in 20 19, right before Corona. And what we did here is we deconvolved a large focal spot. So what we did is we measured specimens with our tabletop CT system, and our X-ray source had two options. We could measure with a very small focal spot, which results in X-ray images with a very high spatial resolution, or we could use a very large focal spot, which has a higher tube output, higher tube power, but due to the large focal spot results in significant tube blurring. And this is what you see here. If you compare the small focal spot to the large one, you can clearly see that anatomical structures are basically blurred in acquisitions with the large focus. And what we did is we used a neural network to deconvolve basically the large focal spot and to obtain images that look similar as if they were acquired with the small focal spot. So our basic idea was, okay, let's always measure with a large focal spot, have fast measurements, have a high tube output, and afterwards we can restore the spatial resolution. And this worked quite well and already illustrated for us the potential of this new technology, basically. Another topic we came up with was scatter estimation. So left, you see a head scan with severe scatter artifacts. And what we want to do is we want basically to correct for these scatter artifacts, if possible, in real time. So you can do it at a scanner and obtain very nice and anatomically accurate reconstructions as shown on the right-hand side. You all know that X-ray scatter is a major cause of artifacts in CT and cone beam CT. So appropriate scatter correction is crucial to maintain the diagnostic value of the CT examinations. If we would only have primary radiation and reconstruct it, we would end up with a very nice reconstruction. Unfortunately, our measurements always contain scatter, and the combination of primary and scatter results in images shown here, which do not have diagnostic quality. So we somehow need to get rid of these scatter artifacts. The gold standard for scatter estimation are Monte Carlo simulations. So what you do there is you simulate a large number of photon trajectories, and this approximates the scatter distribution in your measurement quite well. Unfortunately, per tomographic dataset, such a Monte Carlo simulation takes roughly 1 to 10 hours. So this is nothing you can do in clinical routine. So we came up with a neural network. This is basically a UNet architecture, and we made this UNet estimate the scatter distribution in acquisitions we showed it. This is what we trained it to do, and ultimately, this is possible within only a couple of seconds. So basically, the input is an intensity image in this case, or projection data in general, and the output is a scatter distribution that we can use to correct the scatter artifacts in our reconstructions. Of course, you need a lot of training data. So what we did is we simulated a vast amount of projections. We simulated all available tube voltages. We simulated different scatter ratios and things like that. And on this slide, you see different view angles for an anthropomorphic head phantom in the first column. Then you see the scatter ground truth in the second column, and the other columns are results. Kernel and hybrid-based scatter estimations are basically algorithms that were proposed in the literature that we are comparing against. And DSE, or deep scatter estimation, is the algorithm I just showed you using the neural network that we developed. And we could illustrate that using this deep scatter estimation, we accurately are able to predict scatter and, of course, also to correct for it. And we can do that better than other conventional algorithms. This can also be seen from the actual reconstructions. Left-hand side is the ground truth image. Next is an image without correction, so it's degraded by severe scatter artifacts. And then we have two reference methods, the kernel-based and hybrid scatter estimation. They work quite well, but in particular, the kernel-based method shows some streaking artifacts. And if we now have a closer look at the deep scatter estimation, we find that this reconstruction does not contain any artifacts, and the difference to the ground truth is minimal. So what we actually do here is we use artificial intelligence in neural networks to speed up very slow and costly computations and basically make that able to run in real time. This is what we did here. We also not only simulated that, of course, we also measured that using our in-house tabletop setup. And in that case, our reference is a slit scan that shows only limited to non-scatter artifacts. And also in that case, we were able to show that the deep scatter estimation is able to correct all the artifacts, and this is quite a nice result, I think, because as I already told you, this can be done in seconds on a scanner. So this is a very viable method to be implemented in clinical routine. Something else that takes quite a while in clinical practice is the estimation of dose distributions. One might ask, why do you want to know the dose distribution in a patient? Well, of course, one application is the risk TCM algorithm I just showed you a couple slides before. But of course, it's also useful to study dose reduction techniques if you implement a novel tube current modulation, if you want to investigate pre-filtration and shaped filtration. And of course, you want to estimate the patient risk. This is also one of the main applications. However, this is also not possible in real time. And however, you are aware that the ionizing radiation in CT is still a concern to public health. And so far, we only have a very limited, let's say, repertoire of variables that we can use for risk quantifications. You all are aware of the fact, I guess, that CDDI is not really a patient dose, but rather a measure for tube output, for example. So this is, for example, illustrated here. So the CDDI is something that's estimated using CDDI phantom. And this, of course, does by no means correspond to a human being in any way. Again, the gold standard for those estimation are Monte Carlo simulations. What you see on this slide is just a schematic how that would work. So we basically simulate photon trajectories inside our patient, and we obtain a radiation dose profile per view angle or per projection. And on the right-hand side, you see the cumulative dose as it accumulates over a scan of 360 degrees. And of course, again, this is very, very slow. Again, 1 to 10 hours per tomographic data set and not viable for clinical routine. And there are other methods, of course. As I said, Monte Carlo is the gold standard. There are also analytic linear Boltzmann transport equations. And of course, there are very rough estimates. For example, you can use the dose length product and conversion factors to compute like a patient dose. However, these methods are fast but less accurate. And again, what we wanted to do is we wanted to speed up the dose computations. Again, we use a UNet for that. And we call this algorithm the deep dose estimation. And what it actually does is, in this case, we use as an input not only our CT image, but also a first order dose estimate. And this first order dose estimate can be obtained in a couple of seconds. So this is not a bottleneck here. And we trained it to Monte Carlo outputs. So basically, what this neural network does is we feed in a CT image, a first order dose distribution, and it outputs us the dose distribution for our specific patient, which just showed it. And this is possible in only a couple of seconds, and this makes it almost real time. Here are a couple of examples. In this case, this is a thorax scan. You see the first order dose estimate top right. Bottom left is the Monte Carlo ground truth, and the result of our deep dose estimation is shown bottom mid. And it's quite accurate. The relative error is rather small compared to the Monte Carlo, and also the runtime is rather short. So for example, for a whole body, the Monte Carlo simulation would take like 20 hours, and this deep dose estimation can process all slices for an entire whole body scan in 5 seconds or less with newer GPUs. So this is something that we think is very interesting because it would allow to estimate a radiation dose on a per patient basis for every patient that receives a CT scan, and with that also basically reduce radiation dose. These are some other examples. In this case, for a pelvis phantom, results are similar. Monte Carlo simulation takes forever, and a neural network approach is able to do this in like a couple of seconds. To conclude on the deep dose estimation, we showed that it fits to Monte Carlo simulation and that it generalizes to different anatomical regions and is able to account for different fluence fields. And with that, I'm at the end of my presentation and open for your questions.
Yeah, thank you very much, Stefan. Very nice presentation. Great results. Do we have any questions from the audience?
I would have some questions.
Yeah, please go on, class.
For me, so I'm working in the field of artificial intelligence with medical data, and so I'm very interested in how you measure the anatomical correctness. If for example, you showed this on the um, first slide with artificial intelligence, this denoising thing. How do you measure how well your or how good is the performance of these CNN deblurring or this deep blurring CNN?
That's a quite good question. I don't have a measure for anatomical correctness. That's, I guess, one of the major challenges when employing these neural networks. However, what we did here is we just basically did convolve a large focal spot towards a small focal spot. So we do not assume that anatomy changes much because this is basically just a sharpening of the image. But of course, in that case, we just measured mice because it was a micro CT system. If you would want to do that with real patients, you would have to be very careful, I guess. And I guess this is a topic of ongoing research. But I don't have an anatomical metric for you. Sorry.
Okay. And so you just compare how much. So just for example,
we just measure the pixel-wise loss between
right.
training data. In this case, for small animals, I don't think that this is a big issue. But I agree, of course, in patient, you have to be much more careful.
Okay. Thank you.
Okay, there's one more question, Klaus.
Yes, Stefan, thank you very much. Very exciting work. A lot of technology knowledge that goes into it. So very impressive. Thank you. So I have a specific question actually following up with what Niklas just asked. So can stay on this example and then a more generic one. So I was wondering how you did the training really on this particular example, and the issue that I'm concerned sometimes about is that people use for training two images that are not truly independently derived. Yeah, you mentioned here that you derived the small focus from the large focus. And even though it looks different, there may be some information in the training mechanism that would not be apparent to the eye, but may be there. So you might overestimate the ability of AI methods to improve your data. I wonder whether how you dealt with this issue or whether it's not valid for your setup.
Well, in this case, we measured our objects twice. We measured with a small focal spot and we measured with a large focal spot.
Okay.
So we did not blur the small focal spot to obtain the large one. That would not be very fair because you always have to account for variables you do not see. If you measure something, a lot of information are contained in there. You not only have like a large focal spot, you also have like fluctuations in tube current. You also have like focal spot drift if your tube gets too hot or something like that. And that's why we prefer, at least if possible, to actually measure different data sets that basically we want to train on.
Yeah. Okay, great. So you did it as expected, a very thorough job. It's difficult, though, when you talk about human data, because you might have to expose a patient 2 times and with the obvious limitation. Is there a trick that you can tell us that you use for human data, or do you simply have to figure out?
If it comes to at least denoising methods, you
Mhm.
can inject measured data with artificial noise. The noise properties of CT systems are well understood. They can be well calibrated. This also, for example, not only includes the photon statistics, but it also includes correlations between detector pixels and things like that. And these simulations are quite good. So what researchers usually do is they use data that were acquired with a rather high dose for certain clinical applications, and they simulate artificial noise into these data. And this allows them to basically train their neural networks. And I think this is a viable method to go about this.
Yeah, okay. And my generic question that came to my head when I saw your other examples where you had these streaking artifacts and other not so nice problems. I was wondering, have you tried anything to reduce artifacts for implants?
Not yet. I think we don't have a metal artifact reduction project yet. This is, of course, something very interesting and something very typical for CT, because I guess everyone who works in CT at some point develops a metal artifact reduction method. But I think these methods are much more complicated compared to the denoising we just discussed, because basically correcting for metal artifacts usually means coming up with new data to complement your cyanogram. Because in case of metal artifacts, your cyanogram basically is missing some data because due to starvation and effects like that. And what these networks need to do is to come up with reasonable data to fill these gaps in your cyanogram. And from what we already saw in other publications, they are quite good in doing so. And this also basically brings us back to the question of Niklas, because they are good with coming up with new information that might seem reasonable, but these information might change the anatomy if you reconstruct those data. And that's why we need methods to basically quantify also anatomical correctness. It's not enough to just say, okay, we have a low SSIM or we have a small root mean squared error or something like that, because that image might still show artificial structures. And I think this is a huge topic. And I think people should invest more time in basically dealing with such questions rather than just correcting for metal artifacts.
Yeah, I agree. That could be hallucinations as we see in other areas of AI. Yeah.
Yes.
Thank you.
Stefan, I have a couple of questions about risk TCM.
Sure.
So if I got it correctly, you include the effective dose in your cost function.
Yes.
And thereby you need to include the organ weighting factors, which
Yes.
are somehow eminence-based, meaning there's not so much consensus what should be higher. It's a commission of the ICRP that defines what organ has what factor. So my question is if you could use your method to kind of obtain these organ weighting factors and see which of the organs could be maybe more exposed to the radiation conditions that you would have in a particular scan. That makes sense.
As far as I understood your question, I think it's the other way around. We already need those organ weighting factors. Of course, we can predict which organ basically receives what level of radiation dose. However, this does not tell us anything about the radiation sensitivity of said organ, right? So we also rely on ICRP values, basically, as shown on this slide. So basically, this table is somewhat copied from the ICRP, I guess. So we also require these factors. However, what you could do using this framework is you could either change the effective dose to something completely arbitrary, or you could change your weighting factors to, for example, say, okay, in a particular case, I, for example, want to put an emphasis on the female breast. I want to protect it specifically. So you would basically increase the weight of the female breast, and this would make the algorithm spare that organ even more.
Okay. So basically, what the scanner would do would be to reduce the MAS, the number of photons impinging on the patient, but we also have the KV as another setting. So that would be the second question. How far are we from modulating the kilovoltage as well?
Well,
Is something feasible?
modulating tube current is rather easy, and every CT system in practice is able to do that. However, modulating tube current is much more difficult, I guess. Of course, you have these rapid KV switching X-ray tubes that basically can oscillate between two tube voltages, say 80 and 140 kV. But it's very difficult to basically drive arbitrary KV curves. So I guess this is nothing that we will see soon in practice.
Okay. And I guess one final question, if nobody raised the hand, how often do you see that people in the clinic using the photon-counting CT use the small pixel effect? So you said smaller pixels are good for spatial resolution.
It's a
How
very
often
good
is it
question,
used?
yes. Most stock protocols don't use this small pixel effect. They usually measure with the larger detector pixels. The reason is that if you want to measure with these small detector pixels, you also need to have a small focal spot. And having a small focal spot also means to have a low tube output. So these kinds of measurements are very difficult if you have time-critical applications. So it's quite difficult to design cardiac protocols, for example, with the small pixel effect. However, over the last months, I saw a lot of people switching from the standard detector mode to these smaller detector pixels for other applications in the abdomen, in the chest, in the head, and the extremities. And I think this is something people will do more often as soon as also Siemens will provide stock protocols that actually exploit this effect.
Okay, thank you. I see no more questions. If that's the case, I guess, Ronald, we could finish the seminar today. And we would like to thank everyone for joining and wish you a good evening. And thanks to you, Stefan, again.
Thank you again for the invitation.